go over it again next week a little bit. Don't just go with the first article you see on it. You gotta read through that and find what appears to be a good article. How do you know what a good article is? Well, to a very great extent, nobody knows what a good article is. Okay. Make sure it's comprehensive, not just a case report. Also, look for journals that appear to be international, and okay, because what has happened is that a lot of journals have kind of just come out of the woodwork, and a lot of them, who knows if they're any good or not. So look for an international journal, things like Journal of Dental Research, Journal of the American Dental Association. I would say blank Journal of Dentistry. I don't care what the blank is. I don't care if it's Indiana, India, anything. You know, local is probably not that good. Okay, it should be like an international journal. So avoid, like journals, state dental journals, and things like that. I think for the topics you have, you can probably, do better than that. So we have the pleasure of having Dr. Plaza, who's our oral medicine director, has been doing that for a number of years, and talking about oral. Okay.
Good afternoon. I have a little bit of cold, so I don't know if my voice carries over or not, but if it doesn't, just wait, and I try to speak louder. I think I have met your class before, right? So I work in the Division of Oral Medicine, and my area of interest is oral cancer, and Dr. Markovitz was kind enough to ask me to put together a lecture which we've been essentially repeating the same lecture, just updating some of the data. I think you have the PDF. He gave you the PDF from last year, which is very similar. The only thing I changed is the statistics. And I'd be more than happy to, send it to you. I think he has it in his mailbox. So what is oral cancer? Oral cancer is a cancer that arises from the epithelial lining of the oral cavity and oropharynx. That's the anatomical region we are referring to when we talk about oral cancer. When you read papers, they may quote different statistics because they will define oral cancer differently. Some of them may just refer to oral cavity area, some of them more toward the posterior area. So you really have to pay attention and find out what area they are trying to, give you the numbers. That's where sometimes when you go to different websites, the numbers don't quite match. But in general, it's sixth most common cancer worldwide, and the seventh most common malignancy in males. It accounts about 2% of all malignancies. So it's not a huge problem. But in terms of morbidity and mortality, then it is something that you really need to be aware of. They start in the mouth, and this is from 2018. About almost 34,000 Americans were diagnosed with oral cancer, and about 7,000 of them died. Now, this number of death is more than number of death caused or traced back to cervical cancer. So that should give you a little bit of, scope in terms of importance, because all females are very scared about cervical cancer. They go get pap smear on a routine basis to prevent cervical cancer from getting started. But when you think about mortality rate from oral cancer is higher, why are we not so prevention oriented in terms of oral cancer? Why don't we take it more seriously? 95% of oral cancers are squamous cell carcinomas. You haven't had your pathology course yet, and you'll have a great course from Dr. Schneider, and he will tell you all about the pathology you need to know. But in the mouth, we can have many different types of malignancies. And the majority of those are squamous cell origin. They start from the epithelial lining. But you can have lymphomas, you can have salivary gland tumors. They are not so common. That's why the emphasis when we talk about oral cancer is on squamous cell carcinomas. And I think there was a feature right here. This thing is very sensitive. same thing I mentioned earlier. This shows you the exact anatomical region. So when we talk about oral cavity, we are talking about the anatomical region that is bounded by the lips, by the buccal mucosa, hard palate, dorsal tongue, and basically that little box in front. The area that is highlighted in the rectangle, that's the oropharynx. That is confined by the soft palate, where the uvula is located, base of the tongue, and tonsillar pillar. Why is it so important? Because oropharyngeal cancer and oral cavity cancers are two different animals. They have different risk factors, and there are some overlapping features, I will mention that, but in terms of prognosis, in terms of the risk factors, in terms of statistics, are a little bit different. So that's why you really need to know what area you are referring to. Oropharyngeal cancer is, as I mentioned, a big problem, and we'll come to that later. So it's a significant public health problem. Why? Even though the number is not so high, because of the morbidity that is associated with oral cancer, patients cannot go to work, they have to go for radiation, for chemo, surgery, disfigurement, loss of job, depression that comes with it. Therefore, it's a public health problem. And not only the patient suffers from it, but also the family members. So it actually affects the entire family unit. The 5-year survival rate is not so good. It has improved over the past 6 years, but still, 54% for all stages combined is not really a good, successful, outcome for oral cancer. We expect with all the diagnostics, with all the therapeutics that is available to us now, why haven't we been able to make a greater breakthrough? The reason the statistics haven't changed is because of the late diagnosis. Very often the patients are caught very late. So the patient will not come to the office until the cancer actually starts to have symptoms. And when you catch it late, the prognosis is worse. The treatment is much more aggressive. So that's the main reason we are having the poor survival rate. And then if you have somebody with huge cancer in the mouth, the treatment is not just surgery. They have to get chemo, radiation, and that impacts their quality of life. And as I mentioned, there is major psychological impact, socioeconomic impact, and the whole package. And another important issue to consider is that there is racial disparity and ethnic disparity in terms of oral cancer incidence, as well as survival and medical outcome. And there is a definite difference in survival rate between whites and blacks. So these are all the risk factors that we talk about when we talk about oral cancer. Some of them are just hypothetical, some of them are supported very strongly by literature, but I just listed everything. The main two that you really need to know about is tobacco and alcohol. Smoking in any form, tobacco in any form, smoking or smokeless can be carcinogenic. Of course, smoking is worse, but that's the main risk factor that we've been talking about anytime we talk about oral cancer. Alcohol is also just as bad. It desiccates the oral tissues, dehydrates the mucosa, so the carcinogens from the tobacco smoke can be even more harmful. There are other ones. For example, anyone with prior cancer is at risk for additional ones. Anybody who's immunosuppressed is at risk for oral cancer, along with other cancers. Age, the older you become, more likely to develop all sorts of cancers, just because there is a reduction in immunity with aging process. UV light applies to the cancer of the lower lip. There is some data that there is influence of diet in risk of cancer. It's not very strong, but I'll mention that later. Race, African Americans have higher incidence of oral cancer. Marijuana, again, there are some studies that suggest a role for that, not so strong, but just be aware of it. Lichen planus, we don't know what that is probably, but it's a mucocutaneous disease. Patients develop skin changes, sometimes oral changes, and some forms of lichen planus can develop into cancer, so they have to be monitored carefully. The mouse rinses doesn't hold anymore. We used to have something in the market. Areca nut is, or betel nut or pan, is something that is used in certain parts of the world, for example, Southeast Asia, and it is used the same way that the tobacco snuff is used in North America. And there are carcinogenic elements in that substance, and that puts the patient at risk of developing oral cancer. And in fact, in India, I understand that 50% of cancers are oral cancer. Just think of the magnitude of the problem in that part of the world.
Have they shown anything with quarter acre mold things that people smoke?
Yeah, well, it's an early stage. In fact, I do lecture on the vaping, but there is nothing shown with respect to oral cancer directly, because that's the nicotine vapor, essentially. And supposedly the benefit of that is you are not combusting the nicotine, because all the carcinogens are in the nicotine. But there are lots of other harmful elements in there that cause other sorts of problems. There is, for example, popcorn lung and some other pulmonary diseases. But oral cancer has not been found yet. But that's early, just a few years that people are using it. Genetics, and some people don't have any of this, and unfortunately they get oral cancer. So some people just are predisposed to developing various cancers, and oral cancer could be one of them. And finally, viruses. Viruses, when I went to the school, everybody talked about Epstein-Barr causing nasopharyngeal carcinoma, still true. And then they talk about herpes simplex causing some type of cancer. But now, we definitely know HPV, human papillomavirus, is one of the viruses that is linked to oral cancer, in particular oropharyngeal cancer. So we'll come to that again. Okay, smoking, you all know about that. Now, I mentioned that smoking and tobacco are the main risk factors, and if you do both of them, synergistically, the risk goes even higher, and the patient will be even at higher risk. Diet, there is some evidence that certain diets are protective. For example, if you have dark yellow, green vegetables, citrus fruit, keratin-rich diet, for example, there is that's the highest level of evidence we have for keratin. And the high fiber, not so much. Olive oil, everybody knows how Mediterranean diet is good for you. But it can be actually used this for prevention. I put question mark next to that because we don't know enough. I have patients who come. In fact, I had a patient several weeks ago. This gentleman, not a smoker, not a drinker. He have had 3 episodes of oral cancer. He have had 3 surgeries. He has so much disfigurement. I saw him in private practice, and they know that he's going to get another one. But he kind of knows that he has resigned to that fate, that he's going to get another one. And in fact, the surgeon knows there is something in the upper left vestibule, but they don't want to go in right now because how many surgery can you expose the patient to? They're waiting for it to become really bad. It's to that point. And he came for a consultation with me to see whether or not I can offer chemoprevention. And I told him that really there is nothing definite. When I was a resident, we used to put patients on vitamin A derivatives, like retinoids that they used to get rid of the wrinkles. And some patients responded, some patients didn't respond, and then we stopped using it because patients thought that they are good and then they wouldn't come back until they have cancer. So it's not really an FDA-approved method of prevention. And you may come across literature that say there is some support for it, just take it with a grain of salt. And one thing that I have come across recently is that, I think it's called black raspberry. They found that there are some antioxidants or some elements in it. If you put the patient who have dysplasia on extracts of this particular product, it might help. So there are some evidence, but it's not out there, so we cannot prescribe it. This is still experimental. And that's exactly what I told the patient. he had terrible gum disease, and I said, this is something you can do something about, because again, there is some link between inflammation and oral cancer. And I said the link we don't exactly know what the pathogenesis is, but irrespective of that, you have bad gums, you have periodontal disease, get that under control, and it might help your risk of oral cancer too. So some statistics, this is from 2019. It tells you the total number of cancers in men and women, and then it breaks down the cancers in men and women. 20% of cancers in men are prostate cancer, and in women, breast, so that we already know. And for women, they haven't even listed oral cavity cancer as a risk, but women do get that, but not as high as men. That's why the number is around 4%, and that includes oral cavity and pharynx. And that's not a good classification, because pharynx is the entire tube that connects the mouth to the stomach. We are not talking about oropharynx. Oropharynx is only top of the esophagus. So therefore, this number includes so much more, like lower levels of the esophagus, which is not really oral cavity or oropharyngeal area. This gives you some statistics about the death from that. These are estimated numbers. These are not the exact numbers for 2019. So for oral cavity, about 53,000 for oral cavity and pharynx. And the way I calculate it for myself is that I subtract that from pharynx and I get just the oral cavity. So that's one way, like a backdoor approach, because they very often do not give us the number just for the mouth. And that gives you there for both sexes, male versus female, and you can see male have much higher number. And even for the death rate, the numbers are much higher for men compared to women. This is not very clear, but it essentially shows the incidence of oral cancer by gender and race. You can see men definitely higher than women, and in terms of ethnicity and race, African Americans have highest incidence rate of oral cancer. The 5-year survival rate is something that you need to pay attention to. This is the 5-year survival rate. Again, the data is from a long time ago, but it still holds. It's from 2019. I should have changed that one. So it's recent. And you can see the whites versus African Americans in terms of rate of survival. And for every cancer that you look at, African Americans do worse. The survival rate is lower. And when you look at the survival rate for oral cavity and pharynx for African Americans, it's 20% difference. 20%, that's a great amount of difference. Now, why is that? Why do we have such poor survival rate for oral cancer to begin with? We are not even talking about the difference in different ethnicities. Let's just talk about in general. One reason is the fact that patients do not know you can get cancer in the mouth. When I go to the community service event, we take some pictures and we just leave it there, and patients come by and they look at these pictures and say, what is that? Like there is a big lump on the tongue, and we tell, this is cancer of the tongue. And they kind of look at me very surprised. They don't realize that you can get cancer in the mouth. And then you have to explain to them, yes, this is another anatomical site in the body you can get. And then we tell them about the smoking, drinking, and other risk factors. So lack of patient knowledge is by far one of the main reasons. Patients think everything in the mouth is a canker sore, and they delay going to the doctor. Financial barrier is another one. Let's say somebody is very self-conscious and they know that this thing is not supposed to be there. Cancer is supposed to go away in 2 weeks. This has been there for 3 months. They want to go to the doctor, but they don't have insurance. So that might delay another visit until it starts to hurt. When it starts to cause pain, then they go and scrap by and find the money and they make the visit. But then by then, the prognosis is much worse. Let's say they saw the dentist, or they went and saw the physician. The physician knows something is off. The physician wants to refer them, because many people, some GPs do not actually do the biopsy in their offices. Some dentists don't do biopsy in their offices, so they have to facilitate referral. So that's another delay. Then they go and see the doctor. Very often, they don't get the biopsy in the first visit. First visit is just a consultation. I usually, when I see something and it looks bad, I make time to do it right there and then. But not everybody is like that. People are busy. So, again, doing the biopsy might be another delay. And then, once the diagnosis is made, then the patient has to be referred. Usually to an oral surgeon, to a head and neck surgeon, depending on the extent of the disease. They have to go for PET scan, CAT scan. All of these takes time. And all of these have financial component. They don't have, the patient can afford it. If they don't have the money, they have to go apply for charity care in the hospital. So it's not like today you get the diagnosis and tomorrow start the treatment. And there are multiple levels of delay. So in terms of lack of adequate knowledge, that's a very important information. It's a very frequent finding in multiple studies. They have found that the delay is between the time that the patient noticed the problem until they actually went and saw the doctor. Most cases diagnosed when a symptomatic patient went and visited the doctor. They did not go because something was there. They went there because something was bothering them. They also have noticed that usually patients say, well, okay, I'll wait till I have my next clinic. The next clinic might be 4 months from now, rather than just making a visit to go in and get checked out. And some physicians, sometimes patients have medical insurance, but they don't have dental insurance, so they go to the medical doctor for a sore in the mouth. Now, as much as I have a lot of respect for my medical colleagues, I must say that they are not really familiar with the appearance of the oral cancer. And sometimes they assume it's something benign, but the ones that are aware, they immediately refer it to someone else. Very hardly they ever do a biopsy in the medical office. So it's critical to educate the patients about the importance of self-referral, because that self-referral, making an attempt to make an appointment with somebody, has to come from the patient. So this is a female patient from, maybe 5 years ago. She was from India. She had come to see one of their family members, and when she came to the airport, she actually complained to the family member that my tongue is sore, and she brought her in, and it was so indurated and so hard. You haven't really touched anybody's tongue yet, but once you do, you know how it's supposed to feel. It's supposed to be soft and, movable. But this one was very hard, very thick and indurated, and there was an ulcer sitting in there. And I knew that this has been there for a long time. This is not tongue biting, You know what tongue biting is supposed to look like. Sometimes they're very similar, you can tell, but this was clear cut. And the patient was from India, and I tried to get the information from her whether or not she was a tobacco snuff user, not tobacco, the betel nut snuff user, and she actually did not admit it. But the family member said to me, yes, she is using it, I know. And I think that was exactly where she was resting it, and that's what the damage was done. So now the treatment of something for that, we did the biopsy, we got the diagnosis, it was invasive carcinoma, but I'm not the one who is treating this. This has to be referred to a surgeon because the treatment is very, significant. It has to involve removal of the lesion plus a centimeter or a centimeter and a half around the lesion, and that leaves the patient with half a tongue, if they're lucky. And if it's near the floor of the mouth, they have to do a flap there too. It's a big surgery. And if the PET scan or CAT scan shows a metastasis, then they have to go for radiation and chemo at the same time. Okay, so talking about the financial barrier, I mentioned that earlier. It's common for patients who are at risk for developing oral cancer in the first place. Who gets oral cancer? The traditional profile of a cancer patient, oral cancer patient, is somebody who smokes heavily, drinks heavily, is an older person, low socioeconomic status. It doesn't mean that, other people don't get it. I'm just talking about the general profile. That's the group you used to see oral cancer with. Now things are changing, but in general, those people usually don't have money either. So they are from low socioeconomic group. Even if they want to go to the doctor, they usually don't have the means. So they won't go until they are symptomatic. They have found out that between Canada and United States, when they did study, they found out that the median delay from the time the patient felt something and they went to the doctor is significantly different. 4.5 weeks versus 18.4 weeks. Why? Because in Canada, it's socialized care. You just show your card and you go see someone. Here, you have to go to your church and borrow money, then go to the doctor. So, and I have had patients like that who I wanted to do a biopsy, did not have the money, excused himself, called somebody, went and got money from the church, and then came back. So, from between Canada and United States, there is a difference. Health insurance status is an important predictor. You have health insurance, you go. Increased access to healthcare would be another way to break that delay, to get rid of that delay and make the early diagnosis more possible. I mentioned about the delayed referral for biopsy. The patient is referred, but the clinician may not do the biopsy in the first visit. And they have found that sometimes patients do not even follow. You know, it's the best thing to do is to make the appointment for the patient while they're in the office. So they're given the time and appointment. If you tell them, you know what, you really need to see the specialist, they may not go and actually physically make the appointment because they don't understand the gravity of the situation. They don't know what oral cancer is. They don't know how it's treated, how horrible it can be. So therefore, they may put it off. And anyway, who wants to hear that you have oral cancer? Denial is another component of it. So if you make the appointment for them, they're kind of locked into, more likely to follow. Timely referral for biopsy of an unknown non-healing or suspicious lesion is absolutely critical. And both patients and the clinician should realize that. So what about the factors that affect the prognosis? One of them is stage and diagnosis. If you catch it late stage, not so good. And that's critically important because that guides the treatment. And the size of the tumor is also very important because if you have a bigger tumor, it's more likely to be closer to the lymphatic drainage, to the lymphatic chain, so more likely to spread. And that would affect the prognosis and survival. It's important to realize that oral cancer is initially painless. The patient doesn't even know. Sometimes it's picked up as you're examining the patient because the mucosa has an odd color. The patient doesn't even know. They come to you for a dental problem and then you pick up something. So painless initially is symptomatic, but later as it gets bigger, it may invade the vasculature, it may invade the nerves, and that's how it becomes symptomatic. Stage of diagnosis, about 33% of cases are diagnosed at localized stage, meaning that just on the tongue, just on the cheek, it's not spread yet. About 51% has gone to the neck because that's the first area that is spread through the lymphatic, goes to the nose of the neck. And about 10% goes below the neck, goes to the mediastinum or distal side. Now these numbers might be varied, might be different depending on which paper you read. I had to choose one paper and just quote it, but in terms of the trend, it's the same. It's more likely to be in the neck already by the time you catch it, and less likely to be distant, but still happens. And the survival rate goes directly with that. If you catch something at a localized disease, like when it's just like a spot in the tongue, a small sore in the tongue, you just cut that out, and hopefully that's the end of it. You have to see the patient for follow-up on a regular basis, but they don't need chemo, they don't need surgery. And they have more than 80% success rate. Localized disease is very treatable successfully. Regionalized disease, 63%, it's lower. Distant metastasis is almost 40%, so it's not so good. And if you combine all the stages, it can be 60%, but actually the numbers are a little bit different now. So early diagnosis and treatment significantly decrease treatment-associated morbidity. So if you can avoid giving the patient chemoradiation by catching it early, you have done a big service for that person.
So is regional metastasis just confined to the pharynx? Or
Just confined to the neck nodes.
okay.
Yeah, like lymphatics of the superior and you have lymphatic nodes below the mandible, below the chin, in front of the ears, behind the ears, behind it. So you will learn all about this. Usually goes to the neck, regionalized. So oral cancer 5-year survival by stage of diagnosis. It shows that if you catch it localized versus regionalized versus distant, the survival rate just keeps going down. This is the lymphatic drainage of the neck. See how extensive that is. We have this system on either side, right side and left side. The closer to this lymphatic the cancer is, the faster it can spread. So which anatomical region in the mouth do you think spreads the fastest? Do you think it's roof of the mouth or floor of the mouth? Exactly, it's an exam question in third year, so you got the answer already. So buccal mucosa is closer compared to like roof of the mouth. So the closer to the lymphatic, the more likely to spread. And these are the 4 nodes of all the lymphatic nodes that we talked about. These 4 in particular drain from the oral cavity: submandibular, submental, retropharyngeal, and lateral cervical. We can palpate all of these. As the patient is sitting in the chair, we actually do an extraoral exam. We can palpate for the submandibular nodes, submental nodes. These are accessible. The only one that is not accessible is retropharyngeal. That's within the pharynx. We cannot reach it, and but it still drains. But we cannot identify it clinically. It can be picked up when they do PET scan and CAT scan. So this is a patient who came with a script from an outside dentist saying that suspect oral cancer, please evaluate. Look at that node sitting right underneath the mandible. I mean, anybody, even if you're blind, you can see it, right? I mean, you don't really need to go to the dental school. If you miss that, So that is a very obvious node, a big one, and it felt like a golf ball. Maybe golf ball is a bit too big, like a walnut, let's put it that way. And it had the same consistency. You could not move it. It was firm, fixed, and painless. All the features of a bad lymph node. Doesn't mean 100% that is bad, but is high up there. Because if you have a cold like I do right now, I can feel my lymph node. When I touch it, it's tender and it's soft, it's movable. It goes with the infection. Hopefully when I am recovered, this is going to settle down and go back to normal. I won't be able to feel anything. But this was clearly there for a long time to get to that point. And if I have the clinical picture, I don't. But this is another gentleman. Look at the size of the lymphadenopathy. Huge. Now you wonder why did it go that far? I don't know, because this man came with his son and he said, my father cannot put the denture in. When he puts the denture in, it hurts. And I asked the son, did you look at his mouth? He said, oh, no, I'm not a dentist. And I said, well, you could have looked, just lift the denture in your dad. And when I looked, there was a big mass sitting in the buccal mucosa. No wonder he was complaining of not being able to eat or using the denture. And over time, that cancer had metastasized, gone to the lymph node and caused that mass. This is another patient that one of the students picked up during the initial exam and data collection visit. It's not that obvious. You see the little bit of erythema in the ventral and lateral, posterolateral aspect of the tongue. And the student said that when I touch that area, it bleeds, and patient verified that. So usually in early stages, cancer, as it's growing, it needs blood vessel nutrients, so it grows and the blood vessel grows and angiogenesis is taking place. So you may have superficial bleeding from the lesion, and that's exactly what it was happening. But we can't make a clinical diagnosis. We had to do a biopsy, and it was invasive cancer. And you can see the staining on the teeth. She was a smoker, heavy smoker, and it was picked up even though she had absolutely no symptoms except occasional blood-tinged saliva from that area. This is another one. This one is obviously something abnormal. It's on the ventral lateral aspect of the tongue. There is a white component, leukoplakia, a red component, erythroplakia, and there is a hint of ulceration there, and this was symptomatic. So we did a biopsy and it was squamous cell carcinoma. This one is in the floor of the mouth. It's a totally different anatomical region, and the patient didn't even know about this. She came completely for a different reason, because again, remember, patients are lay people, they don't know. They think everything is a canker sore. She had a partial denture that had lost the clasp, and she wanted us to repair the clasp. That was the reason for dental visit. And I always tell the students, if you don't get anything out of this lecture, learn that when you go examine the patient, even though the patient comes for a, I don't know, broken tooth or broken cusp or broken clasp, just say, I appreciate your concern, I'm gonna get to it in a minute. Take a minute, look at everything, and then come back to the area of complaint. Because if you just get focused on that thing, you will forget to look at anything else, because people get sidetracked. And then you will miss the big story here, which is exactly what happened to my resident. He was supposed to look at the patient, but just told the patient that we don't repair the clasp in Unit 1, and the patient got upset, so he came and got me to go and talk to the patient and calm her down. That's why I went to the room, and I asked him anything. He said no, but again, I don't listen to anybody. I'll always do my exam because I'm responsible for what I write in my notes, and ethically, I am bound by, ADA Code of Ethics, and also medical legally. I don't want to get sued like any one of you. So I'm telling you, always double check, even though it's your husband, your spouse, anybody, and it's not being disrespectful. It's just, it's a human being. So you don't want to just not check. So I started doing the exam, and I saw, so what is this sitting there? Because everybody was focused on the denture class. And the patient said, oh, I have had it for a while, it's not bothering me. And at that time, I tried to explain to her that this is actually a serious finding. We did a biopsy and it was invasive cancer. The patient was a heavy smoker, she had hairy tongue, she had everything that tells you there could be a problem in the mouth. But irrespective of that, they didn't bother to look at it. So, I mean, this patient leaves your office and goes somewhere else to get the denture repaired, and that person picks up that lesion. How do you think you would look like? Just think about that. This is another case that I saw. I mean, really, a janitor can make a diagnosis here. This is severe cancer, really. I mean, how could it get any worse than this? This poor woman comes from a nursing home. She has Alzheimer's. She cannot vouch for herself. She cannot advocate for herself. All can she say, she can that's how she was expressing her pain or discomfort. And finally, the nursing staff had the common sense to bring her in. And when she opened her mouth, the smell and the odor of necrosis was unbearable. Even though I was wearing a mask, you could smell the necrosis. The whole tongue, half of the tongue was necrotic. And this is not something that happened overnight. I looked at the chart that they brought with her. She was on soft diet for months because she could not tolerate a soft diet. But you just wonder, did anybody bother to open the mouth and see why she can't operate there? Or somebody maybe saw something and they did not bother to arrange for, transportation. I don't really know. I just know that I did not do a biopsy because there was very little for me to do. It's not, I do biopsy for cases that I'm kind of on the, what do they call it, on fence, yes, that's one, yeah, on the fence, because I want to expedite referral. But this one, everybody knows is cancer, and I'm not the one who's going to fix this. So why should I put her through another agony and pain? So I just called a colleague who is going to be receiving this referral from me, and I said, could you please take it from there? They do their own biopsy, they have the biopsy report, they have the slides to double check, and they can do the treatment as needed. So sometimes that's all we have to do, yes.
When you refer someone, do you normally take pictures and then send it to the person?
That's a good idea, but if I do it for pathology, I might, because the pathologist is not seeing the lesion. But if I'm sending it to a clinician, he's going to see the patient as it is. So I don't need to, unless if he says, can you send me a photo? Because sometimes it's very hard to get an appointment. And if they see the photo, then they see how ominous it is, they might kind of expedite it. But normally, no. And the clinicians are in the vicinity and they know me, they trust me, my judgment, so they try to accommodate the patient one way or another. So anyway, I mean, in this case, I did not do anything. I just knew that the patient needs to be treated. And you need a Panorex, or you need some type of a radiograph here to see if the cancer is only in the soft tissue or has it gone into the bone. But she could not tolerate anything, you know. We couldn't even to see whether or not it's involved in the bone. But she would get all that workup done once she gets to the head and neck surgeon's office. Now, SEER stands for Surveillance Epidemiology and End Results Program. This is basically a database that collects data from all sorts of issues related to cancer, prevention, diagnosis, survival, everything. And typically they collect all that data from specific geographic areas, which represent 26% of the US population. So most people who want to do cancer research, they actually use this data and they analyze it, they do, you know, they can come up with manuscripts and papers based on what numbers they get from here. Okay, so this is a traditional risk factor for oral cancer. I mentioned someone who smokes and drinks heavily, is older, and usually they don't take care of themselves, have really poor dentition. I'm just giving you the general, you know, almost there are exceptions to the rule. But since 1975 till 2002, based on the SEER data that I showed you, they showed that there has been a decrease in overall incidence of oral cancer in all ages, genders, and races. Why do you think that is? The main reason is because smoking has become a taboo. The less smoking, less oral cancer, right? In this country, at least, you know, there are so many areas that they are banned from smoking. So people are feeling uncomfortable actually smoking. They have to go somewhere else. So it's not something that is advertised as often in the open. People are aware, more self-conscious. So the decrease in smoking rate, oral cancer incidence has dropped over time. In Europe, the drop has happened, but it's not because of smoking. Because in Europe, last year we were in France, and my gosh, so many people were smoking. And I was wondering, hasn't the information come there yet? But there, they say that alcohol consumption has gone down, and that might explain the reduction in the epidemiology. Now, along with the same thing that I mentioned, along with the decrease in the rate of tobacco-related and alcohol-related oral cancer, which have been the main risk factors for this disease for years, we have a new problem. It is called oropharyngeal cancer, which is that rectangular box I showed you earlier. This is cancer in the back of the mouth. This is not oral cavity cancer. This is oropharyngeal region. And still, smoking and tobacco, smoking tobacco as well as alcohol can contribute to that. And for a long time, that was the risk factor for it. But then all of a sudden, the numbers went up, and they were wondering why. They have found that 70% of those cancers in the back of the mouth now are related to human papillomavirus infection, HPV related. And they are basically predicting that, you know, HPV is causing the cervical cancer, right? Over 130 subtypes of HPV exist, and majority of them are non-carcinogenic, called warts, which are very unsightly but doesn't kill you. But the few types of it, those are carcinogenic, 16, 18, and those are the ones that cause cervical cancer. And they found the same strains also cause oropharyngeal cancer. And they are predicting that by 2020, we will have more cases of oropharyngeal cancer than cervical cancer. Is oropharyngeal cancer an infectious disease? Yes, this is something we are learning. If somebody had told me this 15, 20 years ago, that cancer is an infectious process, I would have laughed. But now we are learning some cancers can be infectious in origin. And oropharyngeal cancer is one of them because they have found HPV has a role in it. So HPV is a mucocutaneous virus, a virus that gains access to the epithelium through cracks. There is a crack in the epithelium, the virus gets in, to get to the basal cell layer. Basal cell layer is the bottom layer. That's where it hijacks the machinery of the cells to produce lots of virions, and then it releases them, and then they go and infect some more cells. So that's essentially the process. So when we talk about oropharyngeal cancer, we are talking about cancer of the base of the tongue, an area that we cannot see or examine. We can't as dentists. ENT can, because they have these long scopes they can put in there and see what's happening down there. And the palatine tonsils, when you have sore throat, your tonsils are swollen, that's the area that oropharyngeal cancer happens, and also the posterior pharyngeal wall. It's very interesting that these cancers are very small. They do a lot of damage, but they're very small. Very hard to actually find the primary. Most patients are diagnosed after they develop lymphadenopathy. They see there is a swelling in their neck. They don't know where it came from. They go to the doctor, they get a fine needle aspiration, and they find out, wow, this is cancer in the lymph node. But where did the cancer came from? So they see the secondary manifestation of metastasis, but they don't know where the cancer is because the primaries are very small, and those are in the crypts of the tonsils. And why is the tonsil is particularly prone to that? Because that's the area that the basal cell layer is exposed. And therefore HPV can latch on and do its damage. There is no other area in the mouth or oropharynx that we have the same histology. That is like things are upside down. And that's what they think is accounting for the predilection for the tonsils to be infected. So one other thing they found out epidemiologically after studying this, they found out that these people, unlike the original group, they had terrible dentition, awful oral health, never saw the dentist, smoked like a chimney, drank heavily. Unlike that group, these people have better oral health, better education. They tend to be white compared to the other group, which were mostly of other ethnicities. They found that these are white and they have more sexual encounters. So it looks like these individuals have like a more promiscuous lifestyle. So, and one other thing they found out is that HPV positive oropharyngeal cancer, remember, 70% are HPV positive, 30% is still tobacco and alcohol, right? So they found that the HPV positive cancer, oropharyngeal cancer, fare better. They respond better to treatment compared to tobacco ones. Those ones are dreadful. They tend to come back and the patients tend to die more likely from them compared to these ones. So that's the only good thing about oropharyngeal cancer. So this is a patient that presents with oropharyngeal cancer with a lump. This is not my patient, I got it from the internet, but the patient presents with a lump. They don't even know they have anything in the mouth, anything in the throat, and they have to be scoped. Sometimes they find the primary, sometimes they don't find the primary. Sometimes I'm in unit 1 and see these patients for pre-radiation clearance. I read the note from the surgeon and says that primary was not identified, but they saw the patient with the secondary manifestation in the neck. Now this shows the difference. When they did the epidemiological studies, they found out that there is a difference between HPV positive and HPV negative patients. For example, in terms of the sites, tonsils and base of tongue, in terms of risk factors, tobacco and alcohol versus sexual behavior, cofactors, one group has poor oral hygiene, the other one more likely to use marijuana. In terms of age, HPV positive one boy, usually 10 years younger. Sex, both groups, mostly men. Incidence of the HPV negative ones, tobacco and alcohol related ones, decreasing. Incidence of the other one is increasing because more sex, less tobacco. And histology, this one tends to be more keratinized, and you can see, you can read it on your own. But this is how they do epidemiological studies. They look at the cohort, they look at the commonalities and the differences. That doesn't mean it holds true in every single case, but they can make some generalized statement, and then later on they do more focused studies and they can prove or disprove what they had originally concluded. So let's talk about why there is a disparity in oropharyngeal cancer amongst African Americans and whites. Because we know oropharyngeal cancer, first of all, main group are men, and we know that African Americans are particularly affected, and we know that they tend to do worse. They are diagnosed with a more advanced stage, and even though they are treated the same way, they don't respond as well. We don't know why is that. Is it because they are diagnosed at a late stage? Yes. Is it because they have poor access to care? They are diagnosed at the same stage, but they don't get the treatment in a timely manner as whites do? That could be part of the answer. Is it because they may have other comorbidities, for example, high blood pressure, history of a stroke, I don't know, other issues that may make the treatment less effective, or maybe the treatment is not offered to them because of all the comorbidities they have. So these are all hypotheses. One other thing that was considered was HPV. Could it be because the HPV plays a different role in blacks versus whites? So they have found that the retrospective studies have shown equal number of blacks and white patients with similar oropharyngeal stage and treatment showed lower overall survival in blacks versus whites. So even though they had the same staging and the same treatment, still blacks didn't do as well. So probably that's not the reason for different outcome. Then they said, let's look at the HPV positivity. They found out that in whites, 34% of HPV, 34% of oropharyngeal cancers are HPV positive, but only 4% in blacks. Why is that? And then we told you that HPV positive cases have a better prognosis. So if you have majority of the whites having the HPV positive type, maybe that accounts for the fact that they have a better prognosis, better survival. But we have to understand, why does the virus discriminate between the whites and blacks? That is a very interesting epidemiological finding. Are whites biologically more susceptible to HPV, and as a result of that, better prognosis compared to blacks? So they did, let's talk about HPV, what it is. It's a DNA virus. It's a small DNA virus that has a predilection for the skin and for mucosa. As a child, you may have had skin warts. I know I did. And the treatment for it is that you go and get that thing from the pharmacy over the counter, you put it, and it basically burns the wart and goes away. But if you scratch yourself, you can transmit it to other body sites, or you can give it to your siblings at home. Particularly if you have, maybe you're not healthy, or maybe you are from a low socioeconomic status, there has to be some cofactors, but it's very common amongst kids, and then they grow out of it. Now, we have no medications for HPV. HPV is a virus that comes, infects the mucosa and the skin, and then the body gets rid of it, just like you get a cold and you get over it. The immune system clears it up. However, if you are HIV positive, if you have a medical problem that makes you debilitated, that HPV is not cleared as fast. It tends to retain. The longer it retains, the more likely that it can do some damage. So, and it is considered a sexually transmitted disease, although that's not the only route. For example, skin warts in kids is not sexually transmitted. It's a contact transmission. As I mentioned, there is no treatment for it. Immune system clears it up. Now, if you're smoking, that increases the risk of keeping the HPV in the epithelium, because smoking causes localized immunosuppression in the tissue, and that maintains the HPV in the epithelium. Now, in women, the women who have multiple sex partners, they are more likely to get various strains of HPV from their partners. Now, immune system has to work even harder now. It's not one strain they have to get rid of. They have to get rid of many strains. So if you have more, it's harder on the immune system and more likely to cause damage in the long run. That's why cervical cancer, one of the risk factors for it is having multiple sex partners. But you can also have one sex partner, but there is something wrong with your immune system, and that puts you at higher risk. So this is an example of the skin warts, and these are examples of the oral warts. They look very similar. But remember, these are caused by non-carcinogenic strains. and this is a terrible picture, but you see a lump there. Is it tonsil or is it a tonsillar cancer? You don't know. You have to compare the right and left side. If something is odd and doesn't look right, those are the cases you will refer. Now, is oropharyngeal cancer an infectious, sexually transmitted disease? Let's look at that. They have found that more than 50% of sexually active individuals will have genital infection at some time during life, but they clear it up, and not everybody gets cervical cancer. Small percentage of those people, about 1% of them, will have oral infection with HPV. Again, that can get cleared up and not necessarily cause oral cancer. Acquisition of HPV in the mouth. How do you get HPV in the mouth? You could have it on the skin, and then you kind of rub it in your mouth, you can transmit it. But one route is oral sex. If the person has it in the genital area and then they engage in oral sex, HPV can gain access from the cervical area or from the male genitalia to the oral cavity. And then remember, once it gets there, if it goes to the right area, like in the tonsillar area where the basal cells are exposed, it can latch on, and if the body doesn't clear it up, it can do the damage. I know that I have to give them a break, but I want to find a place to stop. So we know that there is an evidence that there is a relationship between sexual risk factors and the HPV positive oral cancer. And now, compared to 60 years ago, we see more oropharyngeal cancer because people do things differently. Maybe a few years ago, 50 years ago, it wasn't so acceptable to engage in oral sex. Maybe people do it more often. Maybe people are worried about getting HIV, so they don't do genital sex, they do oral sex, they think it's safer, and then they put themselves at risk. These are all the things that we are thinking about. We don't have an answer, but I just want to tell you, when you're doing epidemiological studies, you are looking at many, many different things. Now, let's look at the African Americans versus blacks. First of all, they tried to study and come up with a reason why African Americans don't have an oral HPV associated oropharyngeal cancer as much as whites do. And they said, based on a study, that more than 80% of young people between 15 and 19, they seem to be sexually active. Now, sexually active means different things, depending on the ethnicity you are from. White males are 2.7 times more likely to engage in oral sex, while with a female, and 1.4 times more likely to receive oral sex. So that seems to be the mode of sexual activity for young white males in that age group. But black males were 1.35 times more likely to engage in genital sex. So how does that translate to what I'm saying? If you have had genital sex at a young age and you have received the HPV that way, your body develops immune system. Because like you remember, if you get a cold, you develop antibody to any type of infection. So that antibody protects you later on if you get oral HPV. So maybe 10 years later, you engage in oral sex, but you already have the antibody in the system, which could be protective. So it doesn't let the HPV that enters your mouth latch onto the palatine tonsil and start the process. Again, this is a hypothesis. Everything I'm saying is a hypothesis. I'm not saying this is fact or truth, but it does make sense. And they have done studies that kind of supports this. So they say that early genital HPV infection may protect against oral HPV infection later on. Therefore, African Americans engage more genitally early on in life compared to whites that engage more orally. So therefore, they may have protection against oral HPV infection. And if you cannot get latched on the tonsils, you are less likely to develop tonsillar cancer due to HPV. You get it because of tobacco and alcohol, but you don't get it because of HPV. And therefore, you will not have the type that has a better prognosis. You will have the type that has a worse prognosis.
Does one strain, there are a lot of different strains. Is there cross immunological protection? So also, if there was more general strain, you would have a higher more people will be positive to those strains. And, does exposure to one strain result in immunity to another?
Right, exactly.
Influenza,
Yes.
cold, a lot of viruses, that's why you need different flu shots.
Right, of course. Now, there is some cross-reactivity, but it's not all the same. So there is overall immune response. I'm not an expert in immunology, but this is just a hypothesis that perhaps early HPV infection through genital route may provide protective immunity against oral HPV, but the strains are the same. The carcinogenic strain is the 16 and 18. There are a few more, but there are few in number compared to non-carcinogenic strains. So I think there is some cross-reactivity. It may not explain everything, but that's one way to look at this data, one way to explain why one group is at risk and one group is not. I just want to do a couple more slides and then we take a break. So that's one way to look why African Americans have a higher incidence of oropharyngeal cancer. But at the same time, we know that African Americans tend to have more advanced disease by the time they are diagnosed. And by the time they are diagnosed, some of those have actually metastasized to other sites. And 20% of blacks and 37% of whites diagnosed with localized disease. So it looks like whites are caught earlier and they have a better response. This one just shows that survival rate for males by stage at diagnosis. You can see for every stage, localized, regionalized, and metastasis, whites have a better response rate or better survival rate. It doesn't matter which stage. Another disparity is the treatment. It's very sad, but you have to accept it. They have found that African Americans do not afford, and they don't get the same treatment, the best optimal medical treatment. For example, they tend to go more for radical breast resection, or they may not be offered the same optimal treatment for various cancers, including oral cancer. For oral cancer, the optimal treatment is surgery. That's the first approach. Unless if the cancer is huge, that they cannot do surgery, or it's impact great vessels or nerves that has a lot of morbidity, then they may not do the surgery. But they feel that clinicians may have prejudice that they don't even realize they have, so they may not offer the best approach to some of the patients that are other ethnicities. Just because of the stereotyping, they say, wow, they're not going to follow the routine, they're not going to stick to the protocol, so I'm just going to give them some other approach, offer them a different treatment. So there is racial disparity even in the treatment. So this is exactly what I said. Surgery is the key modality in the case of oral cancer, and the recommendation of surgery considered a surrogate for better outcome. But unfortunately, blacks are less likely to be given that opportunity. Now, this is a patient who has had tongue cancer, and half of the tongue was removed. Remember that picture I showed you earlier? Imagine that disease was removed, and then they put a graft from somewhere in the body, usually the thigh, and they put that there, and they basically rehabilitate the tongue, and they graft the tongue. This is never going to be the same tongue that the patient had. The sensation is not there. The hair keeps growing because it's from the skin compared to the mouth. And this patient is actually lucky to have something. But some people we see, they have nothing there. The entire tongue has been removed, and they just put a placeholder there. This is another one. The cancer was in the roof of the mouth. So you are essentially looking at the nasal cavity because now this patient has communication between the mouth and the nose. And they will have a special odor from their mouth because they don't have that barrier, and the food and everything goes up there. Even though they have an obturator made to close that artificially, it's never perfect, and they have a funny voice. They talk with a funny voice. Disparity in provider behavior, so we do have prejudice, even though we are trying not to. I always have to keep myself from, putting myself in the place of the patient whenever I'm trying to offer them the best treatment. I always think, if my mom was sitting in a chair, what would I have done? And I think that's a good way to catch yourself when you are trying to stereotype. That's why we take cultural competency, to make sure that we offer everybody the best treatment that they deserve. You cannot discriminate based on the race or ethnicity or age or anything like that. Okay, let's take a break and then we'll continue. Thank you.